So I'm here with Dr. Peter Rantevi and Dr. Mark Peel. And what's interesting about this is that I'm a pediatric critical care paramedic. Dr. Rantevi is a pediatric ED doc, and Dr. Peel is a pediatric ICU doc. And so I'm going to throw this concept out because it's something that I talk about, and I have a keynote on it at conferences, and that keynote was called Kids Are Little Adults. And so what I maintain is that the majority of what you will do in pediatric medicine, at least out of like a really specific ICU cardiac environment, most of that just overlaps with the medicine that you perform in adults. And the only real adjustments that you have to make are just to medication dosages and to equipment sizes. And that when you really, the only thing that really makes a difference is actually dictated by the pathology itself. Like obviously your cardiac defects are going to cause you to treat pediatrics differently. But I want to get your takes on that.
Want me to go first?
Sure.
All right. Well, find me one protocol that's adult versus pediatrics that when you look at the actually algorithm, the flow diagram, is any different from pediatrics to adults. And in pediatrics, it turns out that there's one, which is symptomatic bradycardia.
I was just going to say that.
Okay.
Yep.
However, ILCOR reversed it so that we should not be giving epi to children with symptomatic bradycardia. So we've changed that in our protocol. So if you look at all the protocols, adults and kids, it turns out it's the same. So Mark would agree that, yeah, the anatomy is different and, you know, the dosing is different, et cetera. But we should be thinking of them as the same, especially in EMS. Now, Mark's an ICU doc. So he's dealing with a kind of highly critical, but we're coming in dealing with the drownings, we're dealing with the traumas. And if we're coming in with a different mind, with the wrong mindset, we're not going to treat the patient, and the error of omission is what I worry about. But I would love to hear what Mark thinks.
Sure. So I generally agree with you. It's kind of heresy to say that kids are just little adults. The corollary, though, is what I like to teach, which is that adults are just big kids.
That's right.
And so I enjoy the practice of and teaching of pediatric trauma care. And I open my lectures by saying everything you learn here is equally as that applicable. The physiology, the order of interventions, the things we need to think about first are identical. Yes, we may need to weight-based or age-based our dosing. You provide a way for us to do that. But the physiology is no different. And so we need to think about this. I think this helps adult-focused providers, when they encounter a child, think, this is nothing different, just a smaller patient. I need to make my order of interventions and the resuscitation just like I would with an adult.
Right. Which is why, by the way, the three of us make the best adult physicians. Because when you're in pediatrics, you have to be in tune with the patient. You have to be in tune with the physiology. You're a much better communicator. So I think that if you're in pediatrics out there, you should be in EMS and you should come into the family, because pediatric specific folks, I think, are the best EMS folks. What do you think?
I think so too.
The best providers in general. What do you think, Peter?
So the case I make is that, you know, we have this kind of like fear appeal that we have, like that kids just suddenly crash, right? The case I make is that no one suddenly crashes unless they are on a predicted clinical course to suddenly crash. So if someone suddenly crashes, then you weren't paying attention.
Shame on you.
Right? But you know who does suddenly crash? Geriatrics, because they have all these comorbidities and polypharmacy, and they're the ones that are just like looking at you smiling and seem like they are perfectly normal, and then suddenly they go into cardiac arrest. But we don't say geriatrics aren't shriveled adults, right? Like our whole paradigm is just messed up there, right?
I love that.